This is a common chromosomal disease tutorial presented by the SchrDbb with reference ABC of Clinical Genetics by Helen Kingston. So here you're going to visualize the common genetic chromosomal disorders. So you need to know that generally I've already said that the common chromosomal disorders, when you have a chromosomal disorder it's a disorder which is due to either a numerical or a structural disease of the chromosomes. When I say numerical disease of the chromosome, means that there is an addition of a set or one chromosome. And when I say structural disease of the chromosome, it means that there can be a deletion, an inversion, or even a translocation, with even all the different things we have seen in the latter chapter, in the previous chapter, sorry. So those are the chromosomal disorders. So the chromosomal disorders are the disorders which are involving the growth structure of the chromosome. Now, the first disorder that we're going to visualize in chromosomal disorder is Down syndrome. So Down syndrome is actually the most common cause of Down syndrome is trisomy 21, but you can have other causes of Down syndrome. So this is an example of a case of a child with chromosomal disorder who has a dysmorphic facial features and developmental delay. This is because of a deletion at the chromosome 18. So deletion of chromosome 18 can give you this type of face. So now the next thing that you have inside here, we have Down syndrome. So I've said the commonest form of Down syndrome is trisomy 21. Is it clear? So, and then the children are the probability of growth of children with Down syndrome is 1 in 650 to 1 in 800. So those are the probability for the growth of Down syndrome. So most conception, so the Down syndrome most pregnancy can continue to most conception with Down syndrome do not survive, but 2/3 of the conception miscarry by the missed trimester and 1/3 of the remainder is before term. Are you getting? So most of Down syndrome do not survive. So that's 1/3 is the only part that survive, and then the remaining 2/3 don't survive. And then in that 2/3 that don't survive, you have 1/3 is going to be eliminated during the first trimester, and then 2/3 is going to be eliminated in the second trimester or the mid trimester. Is it clear? So those are the things inside Down syndrome. Now the next thing again inside Down syndrome is what are the causes of Down syndrome. Is it clear? So the causes of Down syndrome are mostly divided into 3. The first cause of Down syndrome, as you can see in this image, is trisomy 21. So that's the first. So as I was saying, the first cause of Down syndrome is trisomy 21, meaning that there's an addition of chromosome 21. So the karyotype of this child is going to be 47XX or XY plus 21. So that is the first form of Down syndrome. Second form of Down syndrome is going to be a translocation. So due to a translocation. And then the third form of Down syndrome is due to a mosaicism. As you have seen, there are certain cell lines that are normal, and then certain cell lines have abnormalities. So the Down syndrome mosaic is clear. So those are the different causes of Down syndrome. Now you need to know that the first cause of Down syndrome, which is trisomy 21, is due to a non-degeneration, and when a child has trisomy 21, the recurrence risk in the mother or the child is the recurrence risk because of the mother is going to be very low when you have trisomy 21. So, and this trisomy 21 Down syndrome increases with the greater the maternal age, but the recurrence risk is low when you have Down syndrome due to trisomy 21. But if you have Down syndrome due to translocation, it means that it is the parent chromosome that are fault. So it means that the child is going to have a higher recurrence risk. Is it clear? So now, how do you make a diagnosis of Down syndrome? So diagnosis of Down syndrome can be done on the history taking and physical examination. So it's certain criteria that the patient with Down syndrome has. So you start with the face. On the face, you have slanted eyes at the level of the eyes. You have flat occiput at the level of the skull. You have slow setting ears. It means that the ears are lower to the line. You can draw a line from the outer, a horizontal line from the outer canthus of the eye. The outer canthus of the eye, you're going to realize that the ears are going to be low compared to that horizontal line from the outer canthus of the eye. Then you also have macroglossia, means that the tongue can protrude outside. You have wide nasal bridge, so those are on the face. Now on the hand, you can have only one palmar crease. You can have brachydactyly. Brachydactyly means that what? It means that your fingers are short. You can have very short feet finger. So the feet finger is very short. It has also a name on itself. And then we have also, so those are certain characteristics that you have. And then also on the foot, you can have also brachydactyly, and you have short fingers. So those are the different characteristics that you have a patient with Down syndrome. And the patient with Down syndrome has different risks, as you can see, a Down syndrome risk. So most cases of Down syndrome, so I've already explained this, is due to trisomy 21. That is 90% of cases. 5% of cases due to translocation, and then the remaining percentage is due to a mosaicism. Even 95% of cases is due to trisomy 21. 4% is due to translocation, and only 1% is due to mosaicism. Now, the complication of Down syndrome is that when you have Down syndrome, you are predisposed to certain conditions, like inside the heart, you're going to have tetralogy of Fallot, inside a tetralogy of Fallot, atrioventricular shunt or ventricular septal disease. Inside the gastrointestinal tract, you can have duodenal atresia, or you can have Hirschsprung disease. Inside the endocrine system, you can have a hypothyroidism, or inside the immunologic system, you can have a leukemia. Inside the central nervous system, you can have low IQ. Inside the auditory system, you can have sensorineural deafness. So all these are the complications of Down syndrome. So now this is how a trisomy 21 is produced. So usually trisomy 21 is produced when the maternal age is greater than 35 years. Is it clear? So you can have a father, you have a mother. So this is the mother and this is the father. So usually non-disjunction occurs at the level of the mother chromosome. Is it clear? So you have non-disjunction of the mother chromosome, and when the normal sperms from the father come and fuse with that, it produces three chromosomes at the base set of 23. So you have trisomy 21. It is clear. So you can see these are the ages now, and then the increased risk of trisomy. So you said already that all ages, trisomy 21 is 1 in 650. We have seen this risk. So 1 in 650 people are going to have Down syndrome. So Down syndrome in the general population. But you see that when the age is 30 years, so it's only 1 in 900 that have it. When the age is 35, it's 1 in 385. You see how the risk is increased. When the age is 36, is 1 in 305, and then you see that the greater the age, the risk is increasing. So 1 in 37 people are going to have, the 37 births are going to have Down syndrome. And this here is the risk of amniocentesis. It means that what the amniocentesis shows that the patient is having Down syndrome, and then you don't terminate the pregnancy. Actually, these are the risks that the patient is going to have Down syndrome at the end when the child comes out during birth. Now the next thing you need to know that what you can have a 5% Down syndrome also occurring because of translocation, as I've initially said. Let's say that the parent, so this parent here is normal. You can see this parent here is normal. He has chromosome, a pair set, a normal pair set of chromosome 21, and he has a normal pair set of chromosome 14. But this other parent here is having an abnormal genotype which may not be expressed on the phenotype. Why? Because it's a balanced translocation. So you see, the chromosome 21 and chromosome 14, both of them are acrosomes. Is it clear? And acrosomes have very extremely short p arm. So since they have extremely short p arm, let's say that there is a crossing over between chromosome 21 and 1 chromosome 14. Since the p arm is very short, you see that there is a fusion between the chromosome 14 and chromosome 21 here. So this patient is a carrier of balanced translocation. It means that he has no problem, he has no problems on phenotype, but his genotype is abnormal. You see, he doesn't have any pair of, he only has one chromosome 21, and then he has 2 pairs of chromosome 14, and one of the pair of chromosome 14 contains 1 chromosome 21. So it means that the patient has an abnormal genotype, but the phenotype is normal. Is it clear? Because it's a balanced translocation. Now, when this parent now is going to have a child, you see that this can be you can have a fusion between this and this one. So you have this like that, you have this, you have this, you have this. So this child now is going to be normal. This child is going to be normal. This child which is going to be produced here is going to have also another balanced translocation like his parent. This child is going to have Down syndrome. Is it clear? Usually these other pairs are non-viable. So when you only contain chromosome 21, you have no chromosome 14, they are non-viable. This here is going to be a monosomy 14. This one is going to be a monosomy 21. So this pair here is monosomy 21 is non-viable. Monosomy 14 is non-viable. This is trisomy 14 is non-viable. But this one here, which can also be produced in 5% of cases, is going to be a Down syndrome. And this Down syndrome is now due to a balanced translocation, or you can just say Hobartonian translocation. Now you can have another form of Down syndrome here. So this is a possibility now with Hobartonian translocation. I've already explained this. So this is has already been explained. Now so this is another Down syndrome where the Hobartonian translocation, there is the union between 2 chromosome 21. So this is a Hobartonian translocation. This is another Hobartonian translocation carrier. So let's say that 2 chromosome 21 have united together and then they fuse here to produce still Down syndrome. See, these are the 2 same mechanisms, but here is Hobartonian translocation between chromosome 14 and 21, and here is Hobartonian translocation between chromosome 21 and 21. Is it clear? So they are the 2 same mechanisms to produce Down syndrome. Now the other syndrome that you have trisomy 18. So trisomy 18, so Edwards syndrome actually is usually formed from trisomy 18. So trisomy 18, the overall probability of life is 1 in 6,000 live birth. Is it clear? So 1 in 6,000 live birth. Now, many cases are now detectable by prenatal ultrasound scanning because of a combination of when you have intrauterine growth retardation, oligohydramnios, polyhydramnios, and major malformations that indicated on amniocentesis. So you can think of trisomy 21. Now, the risk of recurrence of trisomy 21 is only about 1% in the general population. So you just have to note that what generally the chromosomal abnormalities, their rate of recurrence is going to be very low for chromosomal abnormality. Is it clear? So these are certain features of a patient with a trisomy 21, a trisomy 18 mosaicism, meaning that what certain cells are normal, certain cells have trisomy 18. So associated with mild to moderate developmental and congenital malformation. So now the next one is trisomy 13, which is also called Pato syndrome. So the incidence of trisomy 13 is 1 per 15,000 live birth. So what I've already realized, but I've never seen it in a textbook, is that the more you are going toward the last pair, so because you have 23 pairs of chromosomes, you have the first pair, you have the second pair, the third pair, fourth pair, till the 23rd pair of chromosomes. Generally, what I've realized is that what the newborns which are compatible with life, the chromosomal abnormality which is incompatible with life, is mostly affecting the pairs which have high numbers. Is it clear? Like 21 is a very high number, 23 is a high number, like in case of Klinefelter syndrome, in cases of triple X syndrome, in case of Turner syndrome, 23 can be affected. So the higher your number, that I've already realized, I've put it as a theorem for myself, the higher your number of chromosomes, the higher the number of chromosomes. Not the higher the number, I'm saying the higher the pair number actually, because the first pair, the second pair, the third pair, if you have trisomy at that level, it is not going to be compatible with life. But if you have trisomy or any form of aneuploidy with a set chromosome number which is high, it is more compatible with life, like in case of triple X syndrome, case of Klinefelter syndrome, like in case of Down syndrome, and all that. So this is Pato syndrome. Pato syndrome, you see the incidence here, since it's trisomy 13 with a lower pair, you said the incidence is also reduced again drastically. So it means that what it is 1 in 15,000 live birth have this. Is it clear? And then about 75% of cases is due to non-junction, and then to about 75% of cases is due to non-junction, and other cases may be due to translocation between chromosome 13 and 14, Hobartonian translocation, as you have seen. Now, the next thing that you have to note is that what are the main features of a patient with trisomy 13? So the main features include, you have macrocephaly, you have holoprosencephaly. So holoprosencephaly is a developmental defect of the forebrain, where the forebrain there is no lateralization. There is no lateralization of the forebrain. So that is the holoprosencephaly, no lateralization of the forebrain. So we have facial, we have eye abnormality, we have cleft lip. So cleft lip, you see, this is a problem of lateralization because of separation and fusion of the both sides of the forebrain and the head. So we have cleft lip, you have eye abnormality, you have palate disorder, cleft palate, you have post-axial polydactyly, you have congenital heart disease and renal abnormality with exophthalmos and scalp defect. Is it clear? But now you need to know that the complication in this case now is going to be mental and physical disability. You have mental retardation, you have epilepsy, you have blindness, you have deafness. So all that is inside trisomy 13 or Pato syndrome. Now the next disorder you are going to have now is chromosomal mosaicism. So this is partial dysmorphology in trisomy 21 mosaic. So if you see, they have already given you the characteristic of trisomy 21 that you can already do it an assignment. So now the chromosomal mosaicism, as we have already said, we said that mosaicism is referred when you have somatic mosaicism. It means that what there are certain cell lines that are going to you have different cell lines. One is normal, one is abnormal. So after fertilization, how does this chromosomal mosaicism occur? So after fertilization, what happens is that what the normal egg cell now divide to produce the different blastomeres, and one blastome is going to have a cell line which is going to do non-disjunction, and means we will have abnormality. That non-disjunction may result to either may result to an aneuploidy that is going to have either a monosomy or a trisomy. Is it clear? So those are that is what happened inside the chromosomal mosaicism. Now the proportion of each cell line varies among the different tissue, and this influences the phenotypic expression. So different tissue can have different cell lines. It depends on the tissue in which, like if you're in the heart, you may not have the Turner syndrome, the Turner syndrome mosaicism greater there. But if it's at the level of the endocrine tissues or the uterine tissues, you may have higher expression of the Turner syndrome mosaicism, because Turner syndrome is characterized by amenorrhea. So the cells of the endometrium have a higher Turner syndrome expression than other cells of the body. Is it clear? The next thing that you have to know is that the clinical effect of mosaic abnormality detected prenatally is difficult to predict. So you cannot easily predict, because this is an abnormality that occurs because of your own cells. It's not because of the parents that you have the mosaicism. Is it clear? The mosaicism does not depend on the parent, but it depends only on the child. So it's difficult to predict. Certain child may have it, certain child may not have it, and we don't know particularly the cause of that mosaicism and the initiating factor. So mosaicism for a marker chromosome carries a much smaller risk of causing mental retardation. So if you have mosaicism, your child is going to have a less higher risk for mental retardation and others. So this is an example of a trisomy 20 mosaicism defect in the amniotic cells. Now the translocation. So let's define what is translocation. We have already defined translocation in the introduction chapters, and we define translocation as being a transfer of genetic material from one chromosome to another, which can either be balanced or unbalanced. So that is it. So the transfer of chromosome from one to another, which can either be balanced or unbalanced, and then the mechanism of that transfer may be due to an abnormal crossing, or it may be due to a normal crossing over between two non-homozygous pair. Is it clear? So it is balanced when you have a normal crossing over between two non-homozygous pair, and it is unbalanced when you have an abnormal crossing over between two non-homozygous pairs. Is it clear? So that is inside translocation. Now, translocation, you also have now Hobartonian translocation. And Hobartonian translocation is just a transfer of one genetic material to another, and with resulting to a fusion between two chromosomes. Is it clear? So Hobartonian translocation occurs between two and it occurs usually when you have the fusion. They occur between two acocentric chromosomes, and the number of acocentric chromosomes, we have chromosome 13, chromosome 14, chromosome 15, chromosome 21, and chromosome 22 are acocentric chromosomes. Is it clear? So usually when you have this, you may have miscarriage that occur in the first trimester. So this, like this case here, it is a balanced Hobartonian translocation. Why? Because this contains both chromosome 21 and chromosome 14, which has been lost here and which has been lost in this pair. So this is a balanced Hobartonian translocation. Now this is an unbalanced Hobartonian translocation because it contains a trisomy 21. It has a higher pair, an increased pair of 21. You have 21, 21, 21, 14 and 14 here. Is it clear? Now for reciprocal translocation, in reciprocal translocation you have just an exchange in material, while in Hobartonian translocation you have exchange in material and which results to fusion between two chromosomes. Is it clear? While Hobartonian translocation you just have an exchange in material without fusion between the two different chromosomes. Is it clear? So that is with Hobartonian reciprocal translocation. So this is an example of reciprocal translocation. So where there is a translocation between one chromosome 7 pair and one chromosome 11 pair, and you see that the reciprocal translocation does not occur usually between acrosomes. It can occur between merosomes which have the length of the P segment and the Q segment are equal, or it may also occur between telosomes where the length of the Q segment and the P segment is smaller than the Q segment. Is it clear? I said already that acrocentric chromosomes are so we have acrocentric chromosome, we have merocentric chromosome, and we have telocentric chromosome. Acrocentric chromosome, their P arm is extremely short that it may not be seen. The merocentric chromosome, the P arm is equal to a Q arm, and then the telocentric chromosome, the P arm is smaller than the Q arm. So those are the different chromosomes, and in these telocentric and merocentric chromosomes you may have a reciprocal translocation, but in acrocentric chromosome you have Hobartonian translocation. Now we have other structural abnormalities like deletion. So deletion, we have chromosomal deletion may arise de novo. So when you have a cancelling of them, so as the word says, you have deletion of one part of chromosome. Is it clear? So it may be de novo or it may be from the parents. Is it clear? So now deletion, now that you have to know, it can be an intrinsic deletion or interstitial, or it can be an intrinsic deletion, or it may be a terminal deletion. Those are the two main types of deletion. Is it clear? So so we have now the diseases which have deletions. We have Cre-du-Chat syndrome. Cre-du-Chat syndrome, here you have a terminal deletion of the short arm of chromosome 5. If you have a terminal deletion of the long arm of chromosome 5, you're going to produce a myelodysplastic syndrome. And now if you have Wolff-Hicks-Borg syndrome, is caused by the terminal deletion of the short arm of chromosome 4. When you have a terminal deletion of short arm of chromosome 4, you're going to produce the Wolff-Hicks-Borg syndrome. Now we have also microdeletion. There are certain microdeletion that may not be seen on karyotyping, because karyotyping you have to analyze. You have the banding system, you have the length, and you have all that which is produced by the Gamester stain on the electron microscopy. Now you need to know that what this banding system, when you have microdeletion, minute deletion that may not be seen with the eyes, you cannot use karyotyping in order to detect microdeletion. You may use another technique which is called fluorescent in situ hybridization, where you create a fluorescent genetic material, that one that can glow on microscopy. You create a fluorescent genetic material that can glow on microscopy, and you attach the pair of the gene you think has been deleted. Is it clear? So you have fluorescent in situ hybridization. So if it does not pair up, it means that that gene has been deleted actually. So this is fluorescent in situ hybridization with a probe from the George critical region. So this the fluorescent in hybridization is having the DiGeorge syndrome pair. Is it clear? So we have the gene that is going to be for the DiGeorge syndrome pair that is on that fluorescent in situ hybridization genetic material. Is it clear? As you can see here, it has glow, so it has glowed red, so you have red signals. So as you can see here, red signals, thus indicating that the other chromosome 22 is deleted, and this patient is actually going to have the George syndrome. So these are the different things that I visualize. Now, example of syndromes which are produced because of microdeletions. So we have said major deletion. Example of syndrome, we have Credusage syndrome, we have myelodysplasia, which is due to chromosome 5p deletion. Myelodysplastic syndrome is due to chromosome 5q deletion, and you have the last one, Wolff-Hirschhorn syndrome is due to the chromosome 4p deletion. Is it clear? Now we have microdeletion which cannot be seen with eyes, like the George syndrome, which is due to the deletion of chromosome 22, the cure band 11. So we have the velocardiofacial. Velo is just the arms. So cardiofacial. So it is a hand-heart face syndrome. Velocardiofacial syndrome is due to chromosome 22, cure 11. Prader-Willi syndrome is due to chromosome 15, cure 11, 13. Angelman syndrome is still chromosome 15, cure 11, 13. Williams syndrome, but the difference between Prader-Willi syndrome and Angelman syndrome is that Prader-Willi syndrome is a paternal uniparental disomy most of the causes, and Angelman syndrome is due to maternal uniparental disomy most of the causes, as we're going to see later. We have also Williams syndrome, which is due to deletion of chromosome 7, and then you continue here, Wilms tumor and iridia. We have all these which are due to different deletion. Now, sex chromosome abnormalities. So still Turner syndrome is that. So Turner syndrome is a monosomy 23 with a monosomy with the X chromosomes. It means that you only have one X chromosome, and usually this patient have a 45 chromosomes. Basically, the incidence is going to be 1 in 2,500. 1 in 2,500 are going to have it. Now you have certain Turner syndrome patients that exist in the mosaicism, where there is one cell line which is normal, and other cell line is going to be abnormal. And now, what are the clinical features that the patient with Turner syndrome have? Usually, they have shield chest, you have web neck, they have widespread nipples, they have valgus deformity of the forearm, valgus cubitus valgus, that is the valgus deformity at the level of the elbow. Is it clear? Cubitus valgus, they have amenorrhea, and they also have this lymphedema of the feet. Is a manifestation of Turner syndrome. So these are the different manifestations of Turner syndrome. Now, triple X syndrome, the incidence means that this patient have triple X, so it's a trisomy X chromosome. So the incidence is 1 in 1,200 live birth. Is it clear? It's a problem with non-disjunction at the level of meiosis 1 with the maternal oocyte. So, or even with the paternal, but usually it's due to maternal. So when you have non-disjunction in patient, usually it's due to maternal disorders and not paternal disorders. So that is it. We have microdeletion at early motor and language development disorders. So this patient have it. So this is a child with a normal appearance with the development of triple X syndrome. So we say that what occasionally menstrual problems are reported in triple X syndrome, but most triple X females are fertile and have normal offspring. So the question is, why is it that triple X syndrome females have normal offspring? The only answer for that is because of the mutilation or the encryption of one X chromosome. We need to know that what, as you have seen in the initial part, we said that what one X chromosome is usually going to be shadowed or encrypted. It's going to be mutilated such that it's not going to be expressed in all cells. Is it clear? So just imagine that the patient has 3 X chromosomes in one cell. One cell, you need to know that all the cells are going to encrypt one X, are going to methylate one X chromosome so that it's not expressed. And when that X chromosome is not going to be expressed, that patient is going to have a normal phenotypic appearance. This is why usually this patient have no disorders. Is it clear? Now, Klinefelter syndrome, this is a male who have XXY. It's a male because anytime you see the Y chromosomes, you must be a male, except you don't have the XRY gene. Is it clear? Because the XRY gene is the gene inside the Y chromosome which expresses your sexual characteristic. Is it clear? And this Klinefelter syndrome occurs in 1 in 600 live birth males. Is it clear? And now the characteristic is that what you have hypogonadism. So since you have hypogonadism, you are going to have a reduced secondary sexual characteristic, like your muscle bulk are going to reduce, your hair are going to reduce, your hair at the level of the chin, the hair at the level of the axilla, so these are the characteristics. Your deep voice is going to be reduced, your broad face is going to reduce. So all these characteristics that are present inside normal males with normal gonadal function are going to reduce in a Klinefelter syndrome patient, and this patient may also be infertile. So those are the different characteristics. So in Klinefelter syndrome you have educational difficulties are fairly common, and behavioral disturbances are likely to be associated with exposure to stressful environment. And I've also forgotten to say that patients also with Klinefelter syndrome may be tall and have also gynecomastia, and they may usually suffer from what is called a testosterone insensitivity syndrome. Basically, some patient with Klinefelter syndrome, meaning that what the testosterone is not going to be active on the different, but testosterone insensitivity syndrome is more associated with another chromosomal disorder than Klinefelter syndrome. But some patients with Klinefelter syndrome have testosterone insensitivity syndrome, meaning that what they have a phenotype of a female just because their testosterone cannot act on the Mullerian, and they cannot act such that they inhibit the Mullerian growth. Basically, so these patients are going to have a uterus, they are going to have all these structures, but they are actually males. So the XYY syndrome. So XYY syndrome occur in 1 in 1,000 live birth males. Is it clear? It is mostly due to non-disjunction in the paternal meiosis 2. So fetal loss is fetal loss is very low. So the next thing you have to know that accelerated growth, you have accelerated growth in early childhood is common, leading to tall structure, but there are no physical manifestation of the condition. Is it clear? So this patient usually they don't have any physical manifestation, they have an extra Y chromosome. So this patient are going to suffer from excess of testosterone stimulation, like in cases of severe act, they have severe act. Their intelligence is within the normal range, so all the characteristics of this patient are actually normal, just like the triple X syndrome. Is it clear? So this patient, they are not usually lost in the fetal life and all that. So from here we are finished with chromosomal disorder. So thanks for your kind attention. Don't forget to like and subscribe for our channel. Thanks.